I welcome everybody to the second dialogue in WGH India's dialogue series. Today we'll be hearing about perspectives from the state level. In our first webinar on Monday, we spoke about community level perspectives, and today we have some very distinguished speakers with us who will bring us the perspective of different states. So thank you so much to all of you for joining. And before I hand over to Deepika, who's our moderator for today, I just want to quickly summarize a few important points, a few crucial points that came up during our first webinar. In fact, it was a very interesting webinar and it was very, very heartfelt. We heard a lot about what Ashas are going through on the field. But just to summarize 3-4 key points from the first webinar, I think one of the things that was highlighted by Surekha Didi, who was an ASHA representative, a general secretary of an ASHA trade union, was that ASHAs are expected to extend the care work that they do at home till outside. So they are not necessarily seen as service providers, they are seen as volunteers. And that's why the distinction between the private and public sphere when it comes to women service delivery people like Ashas on the ground gets blurred. So Ashas are requesting that their contribution be recognized in terms of seeing them as important stakeholders and important contributors of the health system. So that was definitely one key takeaway. The second takeaway was that COVID-19 has made the situation for Ashas worse. They've already are very overworked and unrecognized, but under COVID-19, their responsibilities have increased further, but it has also brought in an aspect of violence and stigma because they are stepping out of home, they're going and testing people, they're doing surveys. So they are had to bear the brunt of people at home and also from the community. So, and finally, the last important key takeaway was that there is no loop, there's no feedback loop in the health system to consider the realities of the ASHA workers on the field, and that needs to change. What ASHA workers experience needs to feed into the health system so that health system policies are more responsive, not just to ASHA's needs, but also to healthcare needs in general. So that actually brings us to a gender angle of the whole issue. The fact is that ASHA women, primarily frontline workers in India, are women. And as long as you ignore the lived realities of women in the private sphere, and as I mentioned, that these realities extend into the public sphere, where we think that care work is the women's domain, and they are supposed to do that care work as volunteers and are not seen as crucial service providers. So as long as the gendered realities of women workers, their lives is not taken into account, the work of ASHAs will also always be challenging, and the system will not respond to what their actual needs are. So that's a quick summary from the key takeaways from our session 1. It was very short. I would request you all to please go through the recordings of session 1, and we'll also share notes. I now hand over to Deepika, who will be our moderator for this evening. Deepika, over to you.
Thank you, Sapna. Thank you so much for giving a quick overview of the community level discussions that we've had in session 1 of our dialogue series. Actually, some very pertinent issues and concerns have been raised by the panelists. So, taking the conversation forward from the community level perspectives to the state level now, we bring to you a panel of esteemed speakers who have kindly agreed to join our WGH India dialogue series, and who will be sharing their perspectives from different states on engaging with frontline workers on COVID response work. A very heartfelt welcome to all the panelists and the audience for tuning in with us. This dialogue series was actually, initiated in an attempt to amplify the voices of the frontline workers, the amazing work that they are doing on the ground, but also to highlight the concerns and challenges that they are facing and to bring those concerns to reach the policymakers so that some concrete decisions can be taken. So this is the second session in the series, following from the first one on community level perspectives. And as Sapna has already shared, quick key takeaways from there. And so from this session, the discussions will be feeding into the third one on national level perspectives, which is scheduled on Friday, same time. So I highly request you to stay on with us through the series. Before we begin, I would like to quickly share a few housekeeping points. Request everyone to please stay on mute if you're not speaking. Only the presenters and panelists will be unmuted. The participants joining us in the dialogue will be able to see a box for questions. So please keep sharing your questions in there. We also have translators on our chat box who will be translating in parallel from English to Hindi, Hindi to English. Do check out if you need assistance in translation there. It might happen that you're not able to access or see the chat window. In that case, you might be logging in through your Android phones, which might not support that particular feature. So you can try logging in through your laptops, desktops, iPads. It should work over there. We'll be recording the session, and the recording will be available after the session. And lastly, for all those on Twitter and other social media channels, please do give us a shout out and share your reflections from the session, tag us there and use the appropriate hashtag. Yeah, so with this, let's get started with the panel discussion. We were really excited to have Uma Mahadevan joining us for the panel discussion, as you would have seen in the, our tweets and other social media posts. But we just heard from her an hour ago, and I want to convey apologies on behalf of Uma ji, who would not be able to join us for the dialogue today, as she had some unexpected commitments to meet at her end. We hope to have her for our future events very soon. So we begin with our panel discussion, starting with Annie Suchiang, who is joining us from Meghalaya. An absolute pleasure to have you, Annie, with us today. Annie is currently working as a state ASHA and community process manager with National Health Mission Meghalaya, and she is associated with ASHA and overall community processes program and interventions since 2007. Additionally, she's also overseeing the implementation of Ayushman Bharat Comprehensive Primary Healthcare Program. So Annie, I would like you to share briefly on what is the situation. We hear these statements like Northeastern region is guiding the entire nation in managing the pandemic effectively. And recently we heard that Meghalaya government has announced that everyone, will be considered as an asymptomatic carrier for the coronavirus. So if you could share, what does this exactly mean for the engagement of frontline workers in Meghalaya? Over to you, Anne.
Thank you, Deepika, and thank you, Kublai Mithila, and thank you to the Women in Global Health India for giving me this wonderful opportunity. And I think engaging me in this very interesting and fundamental dialogue is one of the, it's a good opportunity for me, as well as for, a platform for all the others also. Yes, COVID-19, as it is seen that, it has really shaken the entire global public health system and also countries in terms of their effectiveness in handling emergencies. Meghalaya, for that matter, we were not a unique case. But however, having said that, we were a unique case in the sense that we have practically isolated ourselves, well before the formal lockdown announcement was made. So we had, as a state, the state government has taken a decision to close down, the tourist spots, which is we are well known for. So making such decision was not an easy one, but nevertheless was, I think, a very relevant decision taken much at hand before, the outbreak, or before we had any positive cases in the state. Uh, Also, in terms of, before I go to answering the question on how it's affecting the how all these initiatives has really fall upon the frontline workers, I'd just like to highlight upon a few things which actually the government has done. Even like I've mentioned earlier, that the proactive steps of ensuring lockdown prior to the national lockdown announcement, this was one. But there were three very critical approaches that the government had taken, and along with, while taking, ensuring and making various protocols for the states. One was to prioritize, breaking the transmission chain. Secondly is the ensuring that our frontline workers and the healthcare providers are well capacitated in terms of knowledge and capacity building, and the third thing was to improve the overall health structure. So, COVID-19, on the other hand, would have been had a very negative impact in the health system. But at the same time, if we look at it, it also had some positivity towards it, because this was an opportunity for the state to identify its gap and also strengthen its existing health system. Because I think in the long run, an effective health and an improved health system actually is a support to the frontline workers. If we have a weak health system, it would really have a great impact in terms of the frontline workers in enabling them to deliver the services. So I think these critical steps were very, very effective, and these decisions were very effective in terms of that. And when we decided to bring in, stranded citizens of the state post 5th May, one very key decision that was taken was to that the state would identify every citizen coming into the state as an asymptomatic, and they have to undergo mandatorily, the test screenings at the entry points, and had to mandatorily go test, and they were kept at these state identified quarantine centers, and till the time the test results would come out. And once the test results were out, if they were negative, they would be taken to the community quarantine centers. So we also had community quarantine centers. So there was a linkage between the government and the community as well. So those who were kept in quarantine centers were managed by the community themselves and were supported by the frontline workers. So we had formed around 7,000 community COVID management committees, where the frontline workers were the key, members of that committee, along with the block developmental officers and the medical team. So we had these teams we have these teams who are regularly monitoring the health of these individuals who have come into the state and who are currently under quarantine. Having said that, I think we cannot take away the credit and the efforts and the involvement of the frontline workers like A&M, ASHAs, Anganwadi workers, and also of ASHA facilitators, who sometimes down the line we forget that they even exist. So yeah, so taking all this team together, and with the support of the local traditional bodies that we have in every village and committee, was, I think, the stronghold and the key. At the same time, if we look at the previous year prior to the COVID event, we had seen that, yes, people knew that our frontline workers existed. Yes, they were doing their duties as frontline workers and ASHAs. But when the COVID situation happened, when we had this pandemic in the state, they were furthermore recognized as a very key and crucial critical part of the health system. Because they were treated as the first contact point, and people actually knew their worth, so to say, that they are there and they existed. So And we were seeing evidence across the states where, communities were coming together, giving ashas, honorarium as an honorary award to them. They were collecting food. We had a district administration who collected rations for the ashas because they were in the field entire time. They had no time to buy rations for themselves. So we had seen the district administration and the community coming forward and providing rations to households of ASHA. So we had seen, overwhelming positive response and support to the ASHA in the state, which we had never witnessed before. So these actually became very essential in providing, giving that extra motivating factor for the ashas to go and move out of their homes despite the difficult situation. But yes, when we come to think of the workload that they have, I think it's undeniable, because they are expected to perform their duties, go for surveys, be in the field almost like more than 12 to 18 hours a day. I think, and at the same time providing the essential services that they need to provide, especially to the pregnant women and children who are at high risk. I think practically it's if we come to think of it, it's a superhero job, literally. So yes, it did have a lot of positive impact in terms of community coming together and supporting the ashas, which actually was a key factor in enabling them to perform their duties, but at the same time is still challenging as the days come.
Thank you so much, Annie, for sharing, setting such a good tone for the discussion to take it forward, hearing some really nice initiatives, bringing, community participation into the picture, and how it can serve as a motivating factor, then being recognized and given honorary awards. Yeah, so thank you so much for sharing your perspectives. We'll come back to you for more questions. Moving on to Akshay Minj, who is joining us from Jharkhand. Pleased to have you, Akshay, on the panel. Akshay is a state program coordinator with National Health Mission Jharkhand, and she's looking after the community processes from past 10 years. And she's very closely working with 42,000 Sahiyas, which are Ashas in Jharkhand, and 30,000 village health and sanitation committees of Jharkhand. Akshay is currently engaged in strategic planning of community processes and surveillance activities in COVID response work. So Akshay, I would want you to reflect upon, with Jharkhand being pretty proactive in managing COVID to a great extent, and with this huge migrants coming in the month of May particularly, I think so far approximately 5 lakh migrants have returned back home. How has been, NHM Jharkhand's experience in engaging frontline workers with this huge influx of migrants? The screening and quarantining efforts have to be expanded to a great extent. How have the FLWs been engaged? What are the concerns? If you could reflect a bit upon that. Over to you.
Thank you, Deepika. Thank you, WGH India, for inviting me for this platform so that I can share Jharkhand. Most of the time we used to do many good things, but we couldn't able to express many times. And this is a right time to tell about our frontline worker, not only Sahiya, which is Asha, but Anganwadi Sevikas and multi-purpose worker, which is ANMs, and Sakhi Mandal people, which is self-help group members, and even PRI members. These all together doing some very good role during this COVID period. So the COVID story starts from the month of February only, when we decided at the state level that because our state is a state where high migration rate is there, and we were very much worried about, like, if people will come back from big cities, what things will be happening in the villages. It was very frightening for us that time. And so we decided to have ASHA workers training, Sayyas training. We helped the Sayya to know the importance of common people behavior during COVID time. And like we made them aware of, and you can see that Ashas, they had done a very simple IEC, which was highly appreciated by ministry also. Like they went and by their own handwriting, they wrote in the wall, like wall writing, what is corona, and how to what are the symptoms and where to go. Like ask Sayya. You can see that everywhere people wrote this. So in the community it was there, and then we had given training to Ashas. Almost 60,000 frontline workers were trained on this this whole COVID program, and then they took the village meetings. So before first lockdown, when in the March people started coming, that time itself, in each and every villages, Asha started doing the line listing of all the household where new people are coming, and from that time itself they started home quarantine before government said for the home quarantine. And you must have read in the newspaper like Janta curfew. Each villages they made like human barricading at the village itself, like outside people, the people from the village who went out, they should not enter inside before screening. So Ashas, they were doing like they were informing the CHC, community health center, and CHC team used to come and screen them out for whether if they are okay, then they were kept inside the house, and they had done the survey, and even the home quarantine thing has been done. And like through this process, we had saved at least 1,31,000 people who completed 28 days of home quarantine. And we had done another thing, like through this survey, we took the software thing also to see that which are the areas where district need to focus, like where more migrant have come. So there they worked out, and then you can see in the first round screening that red is like people came from outside, and then after 28 days it was clear. So it is we really feel proud of Sayyas or Ashas who had done a great job, like when community was aware and they had saved at least out of 5 lakh, 1,31,000 were saved through this home quarantine. It was done by Sayya. And after that, when COVID was like in the month of April, when many activities were not in the field, like institutional delivery was a challenge in Jharkhand. Like many facility became COVID hospital. So people or flu corner. So in that facility, people were afraid to go for institutional delivery, or routine immunization was only in the facility, not in the outreach program like VHND. That time we had done another second step is we had done the survey of essential health services of each and every household. Sayya done the community surveillance of line listing of pregnant women, line listing of children of 42 days or 15 months, or immunization age, or eligible couple, then people suffering from TB, leprosy, or and then even for NCD. And based on that, for that survey, we used our PLA app, participatory learning and action, as our ongoing activity of meeting, community meeting, and we are using that app with the help of WGH. So through WGH technical support, we build up one more segment of essential health services in this app, and we collected the information. You can see in one cluster how many pregnant women are there and what all the support we have to do. This we had done through the ASHA, with the help of ASHA survey. And based on that, now state different maternal health cell or child health cell or district people, they started supporting, they started giving the services. Like you can see Asha is with the ambulance for institutional delivery, and they also started visiting the household for survey, and same times like HBNC and HBYC, they started the services. So these in the lockdown period, when people are not able to move, Ashas were on their foot, and they had done the survey, they had helped the people with a social distance and with a proper their own security. Like, and government has also supported Ashas for this. Like they were given the mask, sanitizer, and even it was given through the state. Districts have given their own, but we felt that some of the districts were not so willing to provide these things to Ashas. So our principal secretary and mission director, they also felt that it should be given to them. And one letter went to the district down the line that anybody who is working for COVID, even like for Asha or Asha facilitator or the Asha trainers who are only freelancer, they are also were entitled for the Pradhan Mantri Garib Kalyan Yojana of that 50 lakhs rupees. And like during this time, we found many challenges also, which was in the first dialogue discussions, that during community surveillance time, one Asha was murdered. It was a Naxal area, and that area she was murdered. So within 3 days, we have Sahiya Corpus Fund, Sahiya Sahayata Nidhi. From that, 75,000 rupees went to her family. And same times, this Pradhan Mantri Garib Kalyan Yojana things is moving. And today we came to know that insurance company is coming for the payment of 50 lakhs rupees. And in 2 districts, we found during survey time, like misbehavior of the community. So these Saya, they went to MOIC, that is the head doctor of in charge doctor of community health center. And the first time the health department is supporting Ashas, Sayas, they went with them to the police station, and FIR has been done, and action also has been taken to those people. So in a way, in this period when everyone is seeing, even district administration people, they are honoring Sayas as COVID fighters. So during this time, yes, too much of workload is there for Asha, too much of workload is there for Saya. Still, like when migrants have come to Jharkhand, now they are kept in the community quarantine. We don't, the people who came from outside, still villagers are not letting them to get inside. So they are staying in the outside school or some panchayat bhavan. So these ashas are taking care of them. They are doing the monitoring of everyone, and somehow they are the mediator between the community and the quarantine center. and even to the facility, health facility, and they are providing support to all. So in a way, ashas are doing a great thing. And now health, not only health department, but other departments are also recognizing their work. And like Panchayati Raj department, they are now recognizing ashas, and in their some activities, they want ashas involvement also. Like the the laborer who came from outside and who completed their quarantine in the community center, now they went, they came back to their house. So government is, some district government is providing 5 kg of rice, 1 kg of sugar, and 1 liter of oil. So ashas are going and providing this food to the people who came from outside, the migrants. So in a way, in Jharkhand, if we see the work of ASHA or frontline worker, it is very encouraging, very important in this COVID time. And now the departments are also recognizing them. That's it.
Thank you so much, Akeji, for sharing, the commendable work that ASHA workers are doing on ground. I have a few follow-up questions, which I'll come back to you later, and let us hear, from other panelists as well on their perspectives. So we move on to the next speaker. We have Shubhajit Bhattacharjee. Shubhajit Bhattacharjee is joining us from WHO. He is a medical doctor medical doctor with Masters in Science from London School of Hygiene and Tropical Medicine. He is currently working as sub-regional team leader for 7 northeastern states for WHO, handling the National Public Health Surveillance Project. With more than 11 years of experience working across various public health domains, he is currently engaged in providing technical support to the northeastern states for COVID response work. So, Shubhajit, I would want you to reflect, briefly on what role WHO is playing in providing the technical support to the state governments in northeastern states, in particular reference to the engagement of FLWs. Shubhajit?
Okay. Yeah. Thank you, Deepika, for this invitation and this question. Good evening to all the panelists and all the participants. This is a nice forum, and also thanks the WGH forum. First, I want to tell that this year WHO has declared as a year of nurses and midwives. So this is a special year, and we are facing the pandemic, wrath of the pandemic this year. So, and now we are feeling the system and the whole structure, they are feeling the importance of frontline workers in this year. When it was declared, probably we were not aware that we will be facing a pandemic, but now we can really understand the importance of a frontline workers. So first I want to tell that WHO as a policy, mainly they support the union government. There are various vertical teams in WHO for vertical programs. Like our team, we mainly focus on immunization and vaccine preventable disease surveillance. Earlier, our focus was on polio eradication, and then we had a focus of measles elimination. So already earlier our plan was to complete the elimination by this year 2020. But as we could not do it, we'll not be able to do it. So now it's postponed for next 3 years. And we have other colleagues also. We have some colleagues on TB team. So because the TB is a priority, and also we have colleagues from health system strengthening and neglected tropical diseases. So there are multiple colleagues who are supporting respective state governments. So as a WHO team, we have multiple roles at the multiple states. So what we are trying to do at the various states is that we are trying to give them technical support because many of the Northeast states, there is a lack or dearth of support, technical support regarding the policies, how to go about it, what would be the structure. So we are trying to share the policy support to the respective governments. First, we started with mainly with the capacity building because as you are aware that this is a huge task. COVID is a very new thing, and it's like we are building our sheep during the selling process. So daily there is a change. Even so, people are confused that why there is a change in guidelines, why there is a change in the processes, and you can understand this affects the frontline workers the most, who are our main warriors in the front, because maybe they are not equipped so much to get an updated knowledge, updated information, and also to understand all those complicated technical terminologies and impart it practically in the field. So there are a lot of you can understand there are a lot of changes because as the things are moving in a fast way. So, and also I want to highlight that in Northeast states, what happens that our the communication system is not also at par. You can't reach a frontline worker at the front just directly calling through the phone or a message, because many areas the networks are not there, and other means of reaching them is also not there. Somewhere they have to walk down for 2 or 3 days to reach some village and some hamlets. So, and some areas, even I can tell in Arunachal, there are 2 areas. There is a travel of trekking of 1667 kilometers in trekking in hills to reach a hamlet or village, and that frontline workers are doing. So, with this context, what the WHO team has done, first we have facilitated the capacity building of at various levels, and so that it reaches the frontline workers. So there was a national level training of frontline workers, and we all of us have participated, and we have taken that message and we have imparted that it reaches at the real frontline, and we have tracked from our point of view that whether the participation was at par, whether their learning outcomes were at par, because those were very important indicators whether our workers are equipped to fight, whether our warriors are equipped to fight, because that's very important, because we can't send our warriors without any fighting equipments or something like that. So that's one of the first and foremost thing we have tried to do. Second is that there are a lot of core groups, policy making groups, and task force meetings at state level and district level. So those are very important, because at district level, the district collector, they are chairing, and at the state level, the state principal secretary or the health minister, they're chairing. So there are a lot of decisions taken as per the field input and the practical input. So we are giving inputs on those forums. So what to be done? What is the new thing? How we can do? What are the problems? So those are the forums where we are trying to give our inputs. Third, definitely there are a lot of customized policies being developed from each state. So for those each state customized policies, because there is a uniform WHO guideline, there's a uniform ministry guideline, but the state specific, it has to be customized. This state wants like this state wants like that. So what we are trying to do, we are trying to engage with the state level and try to develop the state level customized guideline, so that it can be state specific, localized, context specific, that these reaches to the frontline workers. Third is definitely what we're trying to support, because if we segregate the whole COVID response, we can segregate in 3 broad pillars. Like one pillar is the policy makers, the secretaries, the officers, the health ministers, the policy makers and executives. One group is the hospitals, the doctors, the nurses who are at the hospitals, taking care, doing the screening and all those things. Another is the frontline workers who are doing the surveillance work and other contact tracing, other work. So there may be 3 different pillars, and there has to be proper linear coordination between the 3 level of pillars. So we are trying to have those coordination between all these different verticals of the system, our health system. And definitely for that, we are trying to assess the hospitals, whether hospitals are set up well to do the proper infection prevention control, because as all of you will be aware that in India, we were somewhat reluctant earlier to practically customize those infection prevention control practices in our hospitals. So now it became very much important. So we were tracking that whether those facilities, like there are a lot of quarantine facilities, lot of hospitals, so whether they are able to maintain that quality of the infection prevention control, because otherwise those will be the source of COVID response. Probably we would have done a good work with the COVID response, but if our major systems are not ready, then we could have missed the bus. Another thing is that definitely we are trying to do is that with the disease surveillance program, because we know there is a integrated disease surveillance program. So there are a lot of data being generated from our frontline workers. So now we are in the world of evidence-based decision making. We need to generate evidence. Like suppose these number of cases came. So what kind of cases are there? Whether they are coming from outside, what is the age group? Which like a lot of things are gradually developing. As I told that we are building the sea where we are sailing. So that's why we need a lot of data, and those data are not being managed properly at various levels. So that we are trying to support the respective state governments to ensure a smooth and real-time flow of data, so that data-based decision makings can be taken. Another support we are trying to give is that there are a lot of positive cases now due to the in-migrants. So for each positive cases, we need to take the details as per the National Center for Disease Control criteria, so that we know what is that the details of that patient. So that's we are trying to support. Another factor is the containment zone. So there is one is containment zone. So where we are doing a containment zone. So containment zone, there are multiple activities. We have to decide the epicenter, the perimeter of the zone. We have to start active surveillance with our frontline workers. So whether our frontline workers are aware what to do when they will be visiting houses. So we are trying to support that containment zone activities, because that's very much a pertinent activity for this COVID response. And another thing we are trying to support in this area is contact and surveillance, is contact tracing, because that's very important. So we have to ensure that our frontline worker is aware who is a high risk contact, who is a low risk contact, whether how to approach them, how to ask them the question, because frankly speaking, that there are now so much cases, and those case histories were not taken by the doctors. Those case histories are taken by our frontline workers, our ANMs, our ushers, our others who lady health supervisors. But those are critical. Suppose I am a COVID patient and I have 50 contact, and the system is not able to elucidate the history properly from me. So there will be, I am missing a lot of people, a lot of transmission chain. So that's very, very, very critical for this intervention COVID response. So here comes our role of our frontline workers. They are trying to take proper history, sharing with their higher ups, because many times people in a fear of stigma and other people trying to hide facts. Then our frontline workers, as they are in the villages, they are giving the appropriate information. No, this is the situation, this is the story. Then the team at the district and the block level, the medical officers, they are able to track it properly with the inputs from the frontline workers. And this is also having a negative effect. It's a boomerang also, it's going. What happens if this kind of informations are given by the health workers? So then that point of time, that ASHA is being victimized. It happened at Assam. What we have seen, that that ASHA, the people was firing on that ASHA, that why you have given that information in one area, but that ASHA has confided that no sir, he has given that wrong information. So that's very, very important step of our frontline workers, because they are stitching the important clues, important dots, because that's required, because we have to be very much specific for this COVID response. Otherwise, we'll miss the bus. There will be transmission local here and there. Another, definitely, as we have discussed, is very important is this. Now there is, the government has started the surveillance of cases like who are influenza-like illness and fever. There has to be intensive surveillance of that, because we need to know who are the persons in the community suffering from those influenza-like diseases or fever. We have to identify them. Doctors should see them, and they should sample them. So I can tell you that Assam has done as a wonderful thing here. Assam Community Surveillance Program, I feel is a pioneer in the whole country. So there is almost 30,000 villages in the state, 28,000 plus 2,000 wards and all. So the ASHA and the frontline workers, it's a 3-day activity. So ASHAs and frontline workers are visiting the respective villages. They are making a line list of the cases who are suspected fever or something like that symptom, with the help of the other frontline worker like Anganwadi workers, and also with the village headman, the Gaon Buras. So they are collecting the data, they're sharing with their supervisor, the ANMs and the lady health volunteers. That's another group of workers. So they are taking the health medical doctor to those villages and areas. They are trying to cross-check those suspected patients, and among them, the persons who are somewhat suspected, they are being tested. The lab technician is accompanying the doctor, and they are collecting sample. So in Assam, I can give you a data. The 30,000 villages are visited by the teams, and 6,500 these kind of cases were identified, and more than 20,000 fever cases were identified, and out of them 4,500 being tested. And the state could find a pocket of local transmission in one of the districts called West Garo Hills, West Karbi Anglong. Sorry. So basically, so this is a really very interesting aspect of these frontline workers. Many of time we don't know what they are doing. They're really leading us from the front. Means they are the leaders. What I can feel, it's not the people who are sitting at the AC rooms and making the policy. They are not the leaders. The leaders who are they are guiding. So that connection is very important. Evidence generation from the front line, connecting it, reaching it to the policymakers, and getting a response. This has to be done. So I will focus on these kind of things. Another thing what I want to focus is that after the COVID, definitely after lockdown, we are revamping our essential services. There was an instruction of ministry and all. You know how it's tough. People are not willing. People are reluctant. I just because I've attended as a panelist as this kind of webinar on immunization after COVID, and there I've discussed in detail that how they are breaking those barriers. They're taking up those challenges because people are fearing that whether they will accumulate. So they are trying to, they're telling that you come to my center, we are ensuring all kind of practices. They are making marking even in the farthest chore areas, which is the islands in the Brahmaputra belt, in the chore areas. Madam from Meghalaya is there. In the Meghalaya, in the areas in the farthest to the hills, we have seen that they are making specific round areas that where the people will stand when they will come for immunization. So they are doing this activity. They are showing hand washing, and they are showing the social distancing or physical distancing. What I don't tell social distancing, because social distancing is not a good term. I feel it's physical distancing. It's not emotional distancing. We should not think of emotion, because that's crossing. Because there was a question somewhere has asked that regarding the mental health, because probably the mental health issue is cropping up due to this emotional distancing. So that's also an interesting topic we can discuss someday. But here what we can tell that these ashas, these ANMs, these health workers, they are breaking those taboos, they are breaking those barriers, and they are the main crux who are leading the fight. So that's why they are ensuring, they are telling, they are convincing, and they are the only person who can convince the people in the front that, okay, we are doing all, we are making a system such like that you can come, you can take the services. And now they are taking those services. So these kind of things were done in the COVID situation. So really, it can't be summarized. It's such a huge activity they are doing in the field. So definitely, what I want to tell that, if in a summary, in a nutshell, that definitely the frontline workers, they are the leaders, they are the main warriors. We need to equip them. We need to build their capacity. We need to motivate them. We need to try to give whatever the logistics required. The government should always ensure, like Madam from Jharkhand, she has told that this Pradhan Mantri Yojana, definitely now they are getting some insurance coverage. That's a good part. But and also definitely there was this social, there were in the society, there are two parts. Somewhere they were stigmatized that this Asha is going to hospital, so some of the people, they're not allowing them to come to their house. So that is the one of the stigma part. But another important part is that they are getting priority in the villages, because the people are relying on those frontline workers, that they are the one of the most learned people in the community who can guide us. And that has happened in the Northeast states, because Northeast states, as you have heard from Madam from Meghalaya, that the community quarantine, community process, so those things are very much structured. The community is very much structured. The village headman, where from the Meghalaya madam, they have the village headman called Rangbashnans and other areas. So those village headmen, they control, but they don't know the technicalities. For them, the people, the frontline workers, they guide. they guide that how to do, what to do. So now they are getting the priority, they are getting recognized for their activities. So this is what I want to tell, that definitely they are the leaders, and definitely means we need to empower them. We need to empower them so that they can win us the race, and they can only win us the race. Thank you.
Thank you so much, Shubhajit. Thank you so much for sharing, a wide variety of, support activities that WHO and also lessons, what other development partners can do to support the state government and what stayed with me was, the statement that you said, we are building our ship, during the sailing process, and the tides are changing every day. And this has been repeated, in the first session, and also every speaker we are having now, so far, that, the ASHA workers and the frontline workers are playing a critically important role on the front line, and it kind of re-emphasizes and reinforces the need to, identify and address their concerns, to take this work forward. Thank you so much again for sharing these perspectives. So now I move on, and bring in civil society to have, what they have to say, what role civil society organizations can play in supporting the government and engaging the frontline workers on ground. So we have Suchitra Rath to begin with. Suchitra is associated with Ekjut, which is a non-profit organization in India, and it has been mentioned by Ake and few others already. So she has been engaged with designing and implementation of participatory learning and action process for more than 14 years for various interventions across different areas of health, nutrition, sanitation, and agriculture. Suchitra, I would like to you to reflect upon that. What role has civil society been playing in supporting the state government? Building upon what other speakers have said about community participation, the role that these ASHA workers have been playing. Sometimes they receive immense positive support from the community. Could you please share a couple of examples on how that impacts the quality of work that frontline workers deliver on ground? Suchitra, over to you.
Perspectives. Hello, can you hear me?
Yes, Suchitra. Yes, Suchitra, we can hear you.
Yeah, sorry. So thank you, Deepika. And I just greeted all the audiences, those who are participating in this webinar. And first of all, I'd also like to extend my thanks to the WGH team and the organizers for giving me this opportunity to share our perspectives and experience in this forum. Like Akai is also here, I'd also like to, at the outset, I would like to say that whatever we are doing in Jharkhand, like the support we are providing to the NHM and the ASHA program, and which is running very well under the leadership of Ms. Akai Minch, whatever we are doing with the Ashas is her work, and her work needs prominence. And I will be touching upon a few points which we are, involved with the government and how we are helping. But before doing that, I'll briefly touch upon about what Ekjut is doing, about our Ekjut's work, and basically involving the frontline workers and how we have been supporting the government. As you know, I'm associated with Ekjut, and Ekjut means togetherness, and our work stands on the pillars of empowerment, equity, and tracking change.
So through a series of our collaborative cluster randomized community-based research trials, and after recommendations that the community mobilization intervention is recommended by the World Health Organization for rural settings, which has low access to health services and National Health Mission. So the National Health Mission invited us to assist them. And if you are aware about the unique capacity building process, which ECJUT has pioneered, and which is expected to bring about many improvements, such as reducing newborn deaths, undernutrition, though along with other interventions, such as home visits and creches or daycare centers, and the potential of this work to address gender-based violence. And even it is also helpful for the support group meetings that are being organized for persons with psychosocial disabilities and their caregivers. You all must be thinking, why am I giving this, this background? So, because now on, I'll be sharing about the platform which the participatory learning and action meetings have given to the frontline workers, and through which how we are engaged with the government. Like women everywhere, and a few of our panelists also mentioned that women play multiple roles. So Asha also plays multiple roles, and Asha are known as Sahyas in Jharkhand, and Sahya means friend. While some envisaged her role to be that of an escort, taking village women to hospital, while others saw her as health workers that she would provide medicines for smaller ailments. So it was also necessary that her role as a facilitator is supported. Through this unique structured participatory learning and action monthly meetings, PLA in short, which is happening across 40,000 villages in Jharkhand and many places in Madhya Pradesh, Orissa, and Rajasthan. That role has been highlighted, and her bonding with the mothers improved through this regular interaction. And what the ashas and the asha facilitators were doing. So the asha and asha facilitators, or the sayyas and sayya sakhis, as referred to in Jharkhand, encourages participation of around 20 to 25 women who take part in a cycle of participatory meetings in which the community members, along with the ashas, they identify and prioritize their problems. They choose the locally feasible and doable strategies for addressing the prioritized problems, and implement their chosen strategies, and together evaluate what has worked and what didn't work. So now when COVID happened, in many places she was asked to become, or so to say, take up a role to inform about who is coming from outside. And we have been hearing from all our panel members, like she is informing who is coming, about their travel history. So and now her role during this COVID time became that of doing a surveillance work, and she was also appreciated for this surveillance work also, and because it was the need of the hour. But a person who was supposed to be for the community, and Sahya, which means friend, to serve the community directly, when her job became that of an informer, that isn't directly in contrast. या ये भी बोल सकते हैं कि directly clashing with her role to serve the community. And now I think the Jharkhand government and other state governments are planning that her informal role should come down, and that her role in contact tracing, etc., can be shifted to the panchayat. The panchayat should be strengthened to take up such kind of role, and she should gradually start doing what she does best. That is making sure that the institutional deliveries are happening, ensuring safe delivery, working in consultation, consonance with the auxiliary nurse and midwives, the ANMs, and making sure that the people are being treated for the smaller ailments so that there are no complications later on, and also conducting meetings. Now, in many places, as Akai also shared few pictures of women, conducting these meetings along with the ashas and the asha facilitators. So they are conducting the meetings of their own, though officially we have not yet started encouraging if these meetings are happening. The bonding, I think the bonding which they have with the mothers, adolescents, and larger community is helping them in conveying COVID-specific messages in a participatory way rather than in top-down instructive manner. And she's also getting support from the community members, especially mothers, to mitigate her COVID-specific additional responsibilities and in dealing with challenges which she is facing because of this the this additional responsibilities. And the second support is uh, when this work was scaled up, there was a need for a dashboard. In this 40,000 villages, when we found that some of the ASHA facilitators have a large number of people to be supported, while others ASHA facilitators had much less workload. So हम लोग reclusterization में help किए government को, and we help the government in reclusterization by directly coming in contact with around 40,000 ashas, and it helped their immense reduction in workload, and their workload also came down because of this reclusterization activity. And this was a significant contribution for their work simplification, and this also helped later on during this COVID crisis. The third contribution that we were able to make is coming up with context-specific evidence on how to use this community empowerment platform to together finding solutions and to seemingly intractable problems of Jharkhand, such as in Jharkhand, women are branded as witches, and there is gender-based violence and severe undernutrition. So these platforms are now being used to dispel stigma associated with this disease, and in also spreading information about the prevention and precautionary measures, and in managing and overcoming the stigma and discrimination associated with COVID-19. So another support is through Ekjut colleagues, who are the members of state and national ASHA mentoring groups. They constantly raise their concerns like timely compensations and workload issues of ASHAs. We have also been flagging the issue of timely incentives of ASHA for PLA meetings and other work. And thanks to Ms. Akai Minch and the community mobilization cell for looking into it even during this COVID situation. And during the last dialogue, we have been listening that Asha didn't have even money to recharge her phone. But here in Jharkhand, the Ashas are paid, the additional amount that they are, uh, uh, they are paid for this for they are from March till June they are paid this additional amount, but now March and April the incentives have already been paid for the ashas and the asha facilitators. And Akai also mentioned about the other team members who were consultant, they have also been incentivized. And one more point which I want to bring in here is that in Wessingham, we are also assisting Sahyas by reaching with ration for marginalized families. She identifies as in distress, or when ashas are helpless and are wanting to help people in distress, there we have been able to provide rations for their families. And she has also helped in linking with other entitlements. Um, so till date, Ashas were discussing about causes and effects with the community, and behavior change happened. They did not be instructive or top down now, and did not tell ye karo, wo karo. So we don't have to keep telling them how they should be sitting and how they should be organizing. So I think when they start these meetings, once she starts talking, they recap some of the basic requirements that physical distance has to be maintained and hygiene has to be maintained. The meetings can start with that people will automatically know how to organize themselves and sit where they will like to sit, etc. The importance of participation exists now also as it was before. Many other values such as empowerment of the communities is needed as before, and the ASHA needs to be supported for this, and we will continue to support the ASHA program as long as we will be called upon to do so. So I want to end by mentioning that all these years, our work was on participation. And after this pandemic, we felt, though for a while, that this is being challenged. But I think we have to go back to our old values of respecting participation, addressing inequities. COVID should not teach us untouchability, but now we have a stronger belief that participation is a key to solve big problems. And even in such big epidemic situations, one size fits all solutions does not work. It has to be context specific. Yeah.
Thank you so much, Suchitra, for sharing interesting perspectives, and also how community participation can improve, work ground, and how critical it is to engage communities in all these decision-making processes. You highlighted the importance of community participation, and I think it's also very important that, given that ASHA workers and all these frontline workers are easily available, we tend to burden them with every additional task, that is coming from the top, because they are easily available and accessible. So a very interesting point that you shared, that,
workers, and mostly they are. It is another issue. I mean, when we talk about the wages, other things, right? So these are the other issues. But of course, this has created a lot of aspiration within the community as well. We have seen a very significant improvement in terms of literacy in those villages. We have seen the aspiration of the parents because they feel that, okay, now even a girl will be independent economically. So even it is notional, but it has a huge impact within the society, I must say. And also it has increased because these were the girls who were not moving out of their villages, right? So, and they were not connecting with the people also. And also, another thing is that in those areas, in our remote rural areas, there is strict taboo where women are not coming forward. So before men, unknown persons. So it is quite foreign to think about that they will share their health concerns or anything issues that are their concern to anybody, which is unknown or with to another. Sex. So that is the difference there. So they feel it comfortable to share. Whatever the challenges, the problems they are facing, even if it is at home, so they are easy to share with. So that was the thing that I take it from here. That of course there has been large number of frontline workers coming out. Not only ASHA, Sahiya in our Jharkhand, and it includes as well Anganwadi workers, Poshan Sakhi, of course. They are also new cadres who are chipping it. So there is a huge cadre coming in. Same, we have, when we look at our structure, we have all kind of jugaad systems, frugal systems that we are trying to innovate continuously within our, this is a big task for the government, the NHM, all are involved and continuously evolving the processes according to the challenges. So this frugal system we are talking about, we have very innovative programs and ideas, and CI and other programs also which rolled out on the ground. And also the big platforms, huge in number, village level platforms, we have VHND, VHSNC we are talking about. So keeping a sync between all these, here we see the role of the communication, which is very crucial to establish, kind of coordination and streamlining among everyone. And given this huge strength we are talking about, we are also in the unprecedented condition of the COVID challenge, which has tested us. Fortunately, looking at this arrangement structure, we also program in some of our rural areas, which are basically mica belt areas, mica prone areas, and mostly very hard to reach areas. So where in those areas we planned, in addition to our staff, a layer of the village volunteers. And this time proved that like Asha, we are talking about like village volunteers. So all who are present within the village are contributing effectively, and I would say that physically they are contributing. For others, it was about restriction movements, getting permissions, or sometimes they are trapped somewhere. It is not possible also to physically cover so much of locations in a time. So this localization was, I must say that it has very positive impact that they are doing on the ground. And also about when we talk about the messaging, of course, it started when we just heard about these things in February, I would say. Then we had mobile messages and everything rolling out. So some of them worked very well, some of them didn't work. When we started our work, so we started on the idea of carpet immunization because our organization was a small organization at grassroots level and we had very limited capacity also. So we thought about carpet immunization, that if we can just saturate some of the areas, so it will just control the transmission over those areas. In one of those tracks, it was in case of Devghar a few years back. So with one of the communities, the village was completely taken out of the immunization roster for 10 years because people felt that it may harm them. So it has disadvantages. Everything was, kind of false notions there. So while we were talking with the team, the frontline workers as well, so we kind of explored the issues. And in the process of village visits, continuously we found that most of the elderly have some kind of vaccine marks on their arm. So then we discussed within the team and with frontline workers as well, and there is the issue that how your father, brought you up, what was the care that they did, were they sensitive or they didn't take care of you, they weren't concerned of you. They said that no, it was fine. My father was caring, my mother was caring. Then they asked that if they were caring, why they put this vaccine mark on your arm? So, because you people are behaving wisely now, then they shouldn't have done it earlier. Did you face any kind of problem? They said, no, it was not. So that was the moment then they felt that, okay, this is kind of self-realization that, okay, this was not harmful for me. So of course it won't be harmful for my child as well. So, and then it was kind of activity planning. Then there was village meeting. People contacted the MOIC there and they said that, okay, look, we can't do anything right now. We can start with some kind of outreach, health outreach camps. We said fine, and then they gradually took it up and it was included again back into the village roster. Likewise, 5 years back when we were doing a program that was 500 First Initiative, where we are talking, looking after kind of ANC pickup. So then we were working with CHAI as well, the Catholic Health Association of India, as well as the health, two of our partners. And NC was not picking up in those areas. So we introduced the examination tables there with some privacy and some kind of playing material at Anganwadi center. So on this helped a lot. So when we are communicating about anything that okay, it should be added with some kind of facility or services. It is not only the messaging that means. I must say that if we are incorporating a basket of service or kind of something, so many organizations have tried it, like incentive, other things, may not be cash or other things, but in different kinds. So with this examination ANC, when they had the private facility, so that picked up, and once that picked up, women started coming regularly to the Anganwadi, and there was growth in number of ANCs as well as immunization in those areas. And when we started working in this COVID response, so we had a meeting with we call Bal Manch. So that is basically Adolescent and Young Children's Association. So they also took a cue from all the messages that were spread. 14 तारीख तक मेरे घर कोई नहीं आना, हम भी तुम्हारे घर नहीं जाएंगे, kind of, and they wrote it everywhere. So that was just starting, but then soon we realized that whatever messages we are promoting, some of the messages, of course, I must say, I must appreciate the effort that the health department, the government, or the district administration in most of the areas have taken up. If the cases are brought up within their knowledge, they have been resolved. Like I must say that in many of the areas, 108 didn't work. So, but then, if the cases were intimated through the village workers, so they were intimated first, that we discussed in many of the districts, and they said that, look, if you start directly that there is a corona suspect, then nobody is coming here because everybody is afraid. So you can say that there is a person who has fever or who wants medical help, and then start this process. Otherwise, the driver will start, just abstain from coming to those areas. So it is good that in those areas, it took the department, us also, around 4 to 6 hours to bring back the patient from the villages to the facility. But yes, I must say that with help of these frontline workers, they were brought to the facility. Some of the communication messages that I must say that we need, because this is also, kind of evolving. We didn't know much about COVID or its nuances or some kind of a finer detail. So it is continuously evolving over the time. Initially it was 1 meter distance, keeping 1 meter distance, and now it is 2 meter distance. So everybody was confused. Like what we should follow exactly. But then there was regular kind of feedback mechanism that okay, it is, when we are talking 2 meter is fine. So it is continuously evolving. So that's obvious that again, one message that needed clarity, that why one should wash their hands minimum up to 20 seconds. So what is the reason behind that? Why should they do that? So we try to work with them also, that we discussed with many of them as well. So, and it helped that once they know that it is essential to just remove out the gel coating that the virus has having. So this 20 seconds is sufficient to dissolve that, and then you will have minimum risk. This messaging, hand wash, I must say that there are many messages which might have been received or not well received, but hand wash is the message which is most received. Hand wash, sanitization. So this is, and also I must say that this was the process of a regular communication channel at frontline workers level. I must say that this is not only working of individuals, it is working as a team, because the relationship you see from BTT, block technical, block training teams to Sahiya Sathis, and then transcending to Sahiya, or even so. And this is the process also, because most of the BTT members have emerged from their kind of experience. So they are handholding it well, and the messages are fine. One more kind of the experience that we did, it was about the integrated farming system, or we say that diversification of food from home sources. So this we did with BRLK, and it was rolled out in 17 districts as well. So this module to improve the diet diversity for malnutrition correction was successful because most of the BRPs were involved, and the message was clear. Some kind of messages I will just appreciate that NSM brought years back. Akaiji was also there, Tiranga Bhojan and other things. So whatever was coming, people were, so it was easy to correlate because nobody knows what protein, carbohydrate, other things like to them. So this was well accepted, the Tiranga Bhojan tricolor. So even in village level meetings, everybody demonstrated that. So we have three food colors, and we are arranging it. So keep and then we are checking our plates also. Availability, of course, that is the issue. For that, we need to work on the supply systems and production system as well. So that was, and one more thing that was still unaddressed. It was about the IFA that we are distributing. So there, I must say that people are not aware about the implications if they are not having. Simply it is handed out and that's all. So there we need to work more on that. That okay, what are the fallouts if you are not taking? In that case, the uptake will be much higher, but still appreciable. That new messages have been introduced, like cooking vegetables in the iron wok. That was a strong message. So this was so far the activities.
Yeah. Thank you so much, Krishnakantji, for sharing, the minute details of how the messaging has worked or sometimes has not worked and what are the lessons. In the interest of time, I mean, I would like to highlight that, we are receiving a lot of, positive comments on the interesting perspectives that different panelists have shared. There are quite a lot of questions coming in, but maybe I'll just take a few recurring questions which are coming in and connecting the thoughts across the panelists. What has come out repeatedly is that given the current context, we are heavily relying on all these communication and training of these ASHA workers through online mode, Suchitra did mention that, ASHA workers there were given, payment for recharging their phone, but, it is highly reliant on the online platform, having access to a smartphone, having access to internet, and there are, Annie and, Akai, Shobhajit, Krishnakant, all of you have mentioned about the difficult terrain. So there were areas where, it is hard to reach. There were network errors. So how has this issue been catered, over there? I'll just share a couple of questions and then maybe one of you one by one can take it and we see how it goes quickly. Okay. Another thing that has, taking the conversation forward from the first session, that the question kept on coming that these ASHA workers have been, on the front line from day one, and they, how are their physical and mental health being taken care of? Particularly, how are they being screened? There has not been much mention about, how are they being screened and how many, ASHA workers or frontline workers do we have with COVID positive, who are tested positive, and how are they being taken care of? Akai did mention about one unfortunate case, but like, are there some strategies or particular attention paid to these frontline health workers? Yeah. Anybody who would like to take, maybe Akai, would you like to take how? Yeah. Akai, you're on mute, I think. Can you speak? Maybe mobile.
Yeah.
Okay. Yes, please.
I'd like to share few of the things. First is regarding training. Yes, I'm totally agree with you, and that's why what we had done for training, like in February we had done physical training, okay, in the month of Feb. Then in the month of March last week, we had done training like refresher and orientation of all district level trainers and district program managers online till the block, and from the block What we had done, all the ASHA facilitators, they came at the block with physical distancing, and they were trained. They were given that, and then they went to the cluster. We have 15 to 20 ASHAs are in one cluster with geographical and socio-political areas. So these are ASHA facilitators. They went to the cluster, and there ASHA came as 10 or 15 ASHAs with physical distance. They training has been imparted through ASHA facilitator, and of course the block trainer was there to see, to maintain the quality. And almost all the ASHA facilitators, they have their Android phone, so we sent a small videos also, and like our recording of our training sessions, presentation and session, so they used that also. So we use this type of training, especially in the high, very tough terrain and inaccessible areas also. And that's why we were confirmed that each and every ASHA, they have a knowledge, and once a person get the knowledge, they will have the self-confidence. And when they have a self-confidence, then leadership comes in the community. So because we feel like ASHAs are not health department staff, in Jharkhand we call Sayyas are the voice of the community. So they still own that they are the voice of the community, they are for the community. Second is regarding physical and mental health of ASHAs. Not only ASHAs, but the other frontline worker. One very bad mishappening took place in one of the district in Jharkhand, especially for this Anganwadi Sevika. Like she was busy with community surveillance team, and her husband came and he misbehaved with him. And next morning she was hanged because there was no mental support or physical support. And that time itself we started helping all the frontline workers. Like we used to have motivational talk to them through ASHA facilitators. Okay. And another thing, like during COVID, we are trying to at the district that whosoever is going for community surveillance in containment area or buffer area, they will go through with the thermal scanning. Okay, so we have only one case of COVID positive ASHA, Saya. She came to the hospital because she was broken to her leg, and at the like my principal secretary was personally looking after that Saya whole history, and we found that she was infected at the hospital, and we are taking care of her. She is in RIMS Ranchi. So like we are trying to support, our state is trying to support the frontline worker, because we want to coin their important role in this whole COVID situation. So our state, two important things which our state had done, that is, one is state made a framework where ASHA's work was minimized. Like we had done one go survey, and we said ASHA will not go once for a pregnant woman, once to line list the children, once to line list the NCD, or once to line list the SARI cases. At one go ASHA will do. And we said ki when the service providing time is now, it is a service providing time. So when ASHA is going to the village, she is taking a package of services for the household, for the family. So like we wanted to just minimize her work because she is really overburdened. She is such a nice, kind-hearted person that if somebody will say in the night, I have the labor pain, she will go with that lady to the hospital. And second thing which we are doing is supporting all field worker in all the stages and all the level. Like all the ASHA workers are having access to my phone number. Anytime they can call me. They call me Didi, not other person.
Yeah.
So
Yeah.
we have that bonding. We want to support, and like my government, they put me in the state health surveillance task force, where chief secretary is chairing the team. So they said that community process is a very, very important role during this COVID time, and always for the health. So this recognition we are getting as a frontline worker, as the community worker, people are started recognizing this state where health system like service delivery
Absolutely.
is not up to the mark, but community is taking care of their health, because health is a state subject.
Absolutely, absolutely. Thank you so much, Ake, for sharing those details. I have another very interesting question which I do not want to miss. So I really apologize, for spilling over beyond 8. Maybe Annie, you can take this up. So there has been a question saying that there seems to be a lot of repetition in the roles of ASHA workers, Anganwadi workers, and ANMs. So which is to an extent creating a lot of inefficiency. So maybe, what do you think about creating role clarity? How about that, significant, it has a potential of significantly, improving and helping each of these cadres to do their job more effectively. How would you like to respond to that? Annie, you're on mute, I think.
Okay, am I audible?
Yeah.
Okay. Yeah, I would put it the other way around. In fact, rather than a role duplication, a role overlap, I would say there's a role confusion, program implementation confusion in the entire team of frontline workers. Because the programs are kind of evolving every day, and newer interventions through different mechanisms are being introduced, and in that way the program has been designed in such a way that it is more like this is what the program is and this is what the outcome is, so that role clarity, role division, and who is going to perform what, and what is the referral mechanism, because I think that's one of the point where we miss out a lot when we say role. Yes, ASHA we know as a mobilizer. ANM is basically the first point of contact who gives the services. Anganwadi worker is basically a support to both these team at the field level. But what happens if an ASHA who mobilizes, where does she mobilize it? And how is the Anganwadi worker going to, support the ASHA in that part? So I think there's an entire role confusion, program implementation confusion, rather than role overlap. So yes, it's very important, especially at the policy decision-making level, that there has to be a proper coordination right from the top level. Because yes, a program division would sit down there, at the top level, decide that these are the key areas, that we need to address as a country or as a state. But then who is going to implement it, and who's going to identify those people, and how are we going to bring them to the to the health facility? So that becomes a big confusion. Like I said in the very beginning when I started it, the health system has to be strong, and only then will the service provider and the frontline workers be able to work. If the health system per se in itself is not strong enough, and it's not clear with the roles, then you can understand that this role overlap, role confusion, program implementation confusion is going to go haywire, and will not meet the outcomes. And therefore we will need apps, we will need we will need data, we will need a lot of so to say, tsunami of data collecting points will start coming at some point of time, which we are seeing this in the coming days. So I've seen ASHAs being bombarded with so many kind of digital platforms for them to use, where they get confused whether to talk to the person who are busy entering the data in their phones. So that interpersonal connection also is kind of, getting somehow reduced and kind of getting disconnected from their actual role. I would also like to add on a few things as well. While designing these program protocols or program guidelines, we have seen that the roles are so much focused upon the ASHAs rather than the ANMs or the medical officers or the supervisors who are there sitting at, at a sub-center level or a PHC level. Those roles, if you go through any guidelines, have not been specified. Any guidelines, program guidelines that you open up and see, you will see role definition of an ASHA, an Anganwadi worker, an ANM. You will not find a role of a medical officer. You will not find the role of, of any other service provider for that matter. So these are the things I think we really need to keep in mind while designing program guidelines and outcome. Another thing which poses as a great challenge to us in our state is the urban context. We fail to touch upon these topics. We know that there are frontline workers working even in the urban areas. So where we see in the rural areas, there's a lot of connection and bonding amongst communities in ASHA, which makes her work much easier. But when it comes to the urban areas, especially, there was a great experience from this COVID incident that we have, the pandemic that we have, where we see that urban areas, the response of people and the connection of people towards ASHA is very less, because they feel they know more. There are many resources that they have available to their disposal. So they don't go to the frontline workers. Frontline workers are the last resort, which is just the opposite in the rural areas. The ASHAs are usually, the frontline workers are usually the first resort in the urban areas. So these are the things I think poses as a challenge, and we really need to look upon these. And that is where role clarity will come in very slowly.
Absolutely. Absolutely. Thank you so much, Annie, for sharing this, how critical it is for, the health system to act upon it and make things easier for these workers to act upon. I'm really feeling sorry. I can continue this discussion like throughout until later night, but in the interest of time, I would rather leave you all and the audience with a very important question. While all these states are honoring the ASHA workers and all these frontline workers as COVID warriors, COVID fighters, awarding them, appreciating their efforts, which is absolutely required, but I would say it's not enough. I mean, we need to respond to their needs as well, and we need to make sure that their dignity is preserved. So perhaps how can the ASHAs be recognized beyond just calling them as COVID warriors, and how can we make things easier in reality on ground? So we'll take, I leave you with this question to reflect upon within your respective workspaces, and we take this discussion forward in the next session with our national level stakeholders. Really apologize for the delay, and I can't take all the questions. So with this, I thank you so much for joining us today. It is a sheer delight, to hear different perspectives from our panelists with some very interesting initiatives, taken by the states, and lessons on how can we take them forward in engaging them in the decision-making process, like Suchitra mentioned. So with this note, I close the session. And I hope you all enjoyed, the discussion, such an enriching discussion as I did. Please reach out for any queries, doubts on membership, future activities of WGH, on the details that are mentioned on the screen. We have our last session of the series scheduled on Friday, which will connect the dots that are plotted in session 1 and 2, and we'll hear from the national level stakeholders to understand, how all of this fits together in the larger picture and what could be the potential way forward. So thank you once again for joining in, and I, on behalf of India WGH, look forward to having you in the next session of the series. Thank you so much.